Hello and welcome to the Social and Behavior Change in Family Planning and Reproductive Health course. My name is Olivia Carlson and I'm thrilled to be here today with two of my colleagues from Breakthrough Action to walk you through the materials. My other two colleagues who you will meet in a moment are Utra Bharath Kumar, who's a senior SBC capacity strengthening advisor for Breakthrough Action at the Johns Hopkins Center for Communication Programs, as well as Zoe Hendrickson, who's an assistant scientist at the Hopkins School of Public Health, as well as a research and evaluation officer at the Center for Communication Programs. And as I mentioned, I'm Olivia Carlson. I'm a program officer working on Breakthrough Action as well at the Center for Communication Programs. By way of background, the Breakthrough Action Project is an 8-year cooperative agreement funded by USAID to lead social and behavior change programming around the world. It's a partnership led by the Hopkins Center for Communication Programs, but we have several partners, including Save the Children, Think Place, Ideas 42, Camber Collective, ICRW, and Viamo. The main goal of the project is to ignite collective action and encourage people to adopt healthier behaviors. So we work in a number of different health areas, and I will show you on the next slide in a moment what some of those are. And we do this by forging and testing and scaling up new and hybrid approaches to social and behavior change. And these approaches are informed by several different fields, including social and behavior change communication, as well as marketing science, behavioral economics, and human-centered design. And then on the right side here, we just have a few examples of some recent resources the project has produced. If you're interested in perusing all of the resources, or these ones in particular, you can visit our website at www.breakthroughactionandresearch.org, and you can find everything we've produced there. As I mentioned, we work across a number of health areas. You can see that on the left-hand side here. Today, we're going to be focusing on family planning and reproductive health, but I did just want to share with you that Breakthrough Action is working across a number of different areas. So if you're interested in any of those areas, I would encourage you to check out our website as well. And also just wanted to highlight that the project brings together experts in several different areas, including audience segmentation, advocacy, behavioral analysis and economics, community engagement, digital, gender, HCD, marketing science, and of course, social and behavior change communication. So there are a lot of folks working across different fields, bringing their expertise to the project. And on the right-hand side, you can see some examples of campaigns the project has implemented. And again, if you're interested in learning more about any of these campaigns, you can find that on our website. So now moving into the agenda for today, this is the end of the introduction and agenda portion of the session. And in a moment here, I'm going to pass it off to my colleague Utra to take you through the Social and Behavior Change 101 overview. And then that will be followed by 3 different sections organized around the Social and Behavior Change Flow Chart, which you will become very familiar with by the end of today's session. But as you can see here, there are 3 phases. The first is define, the second is design and test, and the third is apply. So we've organized our content around those 3 areas and hope it makes things a little bit more digestible today. And with that, I'm going to pass it off to Utra.
Hello, and welcome to the first segment, Social Behavior Change 101, an introduction. You may already be SBC practitioners. You may have a lot of experience with family planning. There's no doubt. Thank you for joining us, because today we're here to persuade you, not to persuade you, but really to stir the glass, to present a few ideas for your consideration. Imagine a scenario where you are in country X, where the vision for individuals and or couples to meet their desired reproductive intentions is there. However, the unmet need for family planning in country X among adolescents is about 28%, fairly high. And this is now your fictional country X, but there are countries where this may be as high. Can you brainstorm and think, why might unmet need among adolescents in country X be so high? Pause this video for a second and write down some of your thoughts on why you think this is. There are actually a great many reasons or factors that can influence behavior. You have individual level behaviors, factors, you have social and gender norms, you also have structural and policy issues that may be a challenge. So what are some of the factors at an individual level? There could be attitudes and beliefs. What kind of beliefs and attitudes exist among young people that might support or prevent practice of the behavior or health outcome? And not just among adolescents, it could be among the people around them, right? But these are influential to the young person. Expectations. What do people feel will happen as a result of practicing a behavior? Knowledge. Do young people know why the behavior is important and how to practice it? Self-efficacy. Do young people feel confident that they can practice the behavior? Do people have the right skills or the training to carry out the behavior? Do they feel a threat? How concerned are people about the outcome the behavior will prevent? At a social and gender norm level, you have gender norms that are defined as roles and decision-making factors between men and women that could inhibit the practice of a certain behavior. So in this case, adolescents can be influenced by gender norms in the community, in their families, in society, with their religion, and so on. Social norms. And what do people think others in their community or social network do? Do they practice the behavior? Do those people actually practice the behavior? Are there informal rules that govern this behavior in the group or society? These are some things to take into account. From a structural and policy level, access and availability can be an issue. Are any of these products or services required, the ones that are required for practicing this behavior, available? Meaning, are contraceptives available? How difficult is it for the target population to access them? In some cases, youth can't access family planning methods. Affordability. What are the financial barriers or supports to practicing the behavior? Policy. Are there supporting protocols, policies, or laws that promote or inhibit or mandate the behavior? In some countries, it's illegal for young people to obtain family planning methods below a certain age without parental consent, or unless they're married. Then there's quality of care issues as well. Does the provider of a required service for this behavior follow quality standards, protocols, guidelines? Are they empathetic? Do they treat the young people with respect? So there are a great many factors that influence individual behavior. So these factors resulting in unmet need can be individual, they can be social norms or gender norms, or structural policy related. The good news is that SBC can help address most of these factors in some way or another, even if it's advocacy for better structure or policy. SBC is a part of the solution, not all of it, but an important part of the solution, because there are other issues as well beyond SBC that need to be in place for young people to meet their family planning needs. So I'd like to present 4 key ideas on SBC for better reproductive health outcomes. There are many ideas, but we've chosen 4 in this context to share with you. The first idea is that there's no ideal public health outcome without social and behavior change. If you can consider national family planning objectives, within those are the social and behavior change objectives. SBC objectives contribute to the overall national family planning objectives. They amplify the effects of service delivery and policy to increase family planning uptake, right? So service delivery, contraceptive availability, all of this is very, very important as well, and as part of the national family planning objectives. However, the SBC objectives are important to take into account because they contribute to the overall family planning objectives. For example, if this is a real story, one of my colleagues was invited to the World Health Organization to make a case for social and behavior change in fighting TB. And he was asked to bring as much data as he possibly could to support his argument for why social and behavior change is really important in fighting TB. However, he went there with empty-handed and said to them, I didn't bring any evidence. And there was a lot of murmuring and dismay, and people were like, how is this possible? He came with no evidence. And he said, okay, give me a second. What are some of the key challenges in fighting TB in your countries? And people came up with things like drug availability, affordability, trained service providers. But they also came up with issues like compliance, stigma, knowledge about what is and isn't TB, the symptoms, treatment seeking, taking their drugs completely, social support for TB, and so on. And he said, well, more than half of the issues that you have cited are related to behavior, are related to social norms. How do you imagine you could address these without an SBC intervention? Right? So what you'd need is not really evidence. And if you need evidence, there's plenty out there. The question is not to keep asking for evidence, but to see how critical SBC is as a part of the larger context in fighting a disease or adopting family planning or any of the health issues you're talking about. So it can amplify service delivery and not instead of it. The second idea I'd like to present is that investing in SBC is cost effective. The business case modeling in Zambia done by Breakthrough Action's sister project, Breakthrough Research, found that every dollar invested in scaling SBC saves between $2.40 and $5.30 when accounting for direct health costs and productivity losses. And this is the days that are lost due to people not working due to pregnancy or maternal deaths or disability, and so on. So if you take that into account, avoiding unplanned pregnancy can actually save money, right? This is a case study for Zambia. There are other countries in which the similar kind of case study has been done, and without an exception, you can see that investing money in social and behavior change saves more money in the long run. So SBC can be cost effective, and we will share links to all of these resources towards the end. Where does SBC usually fit into a country's family planning program, in your experience? Think about it for a second. Where does it usually fit in? Typically, it would be at the very end, right? After you finish designing the program, let's add in some IEC. Let's tack on some posters, right? Some when the program is largely clinical or service delivery focused, at the very end you would add in a few posters, maybe a radio program, something. And usually if there's a funding crunch or a budget cut, usually the communication, the IEC or the SBC gets cut first because it is not really seen as essential. And sometimes funding isn't even available to fund it fully, right? Not strategically. So the third idea I'd like to present to you is to suggest, let SBC be the steering wheel and not the spare wheel, right? Let it be the steering wheel. Let it lead the program. Let's lead with behavior rather than adding it on towards the end, tacking it on towards the end. And when you think of SBC interventions, what comes to mind? What do you immediately think of? Pause the video here and take a second to jot down what comes immediately to mind. It's likely you thought about things like posters, leaflets, and so on. How often does SBC get reduced to this? A program claims that SBC was done when in effect a poster or a leaflet or a community sensitization talk, usually a one-way lecture from an expert to a group of people, happens. And they're like, SBC is done, check. Often, even those are not strategically developed in terms of the content and the audience and the information that's needed. Does it address a barrier? And it's almost never evaluated for its effectiveness. Did the message reach? Was it effective? Did we convey what we tried to convey? So quality SBC that is strategically developed is evidence informed and theory informed, right? It requires good quality formative research to understand what the barriers and facilitators are for the behavior. And then it addresses those facilitators and barriers, individual as well as social and gender norms, to the practice of target behaviors with the ultimate goal of creating sustained behavior change, not temporary behavior change, right? And it's context specific, it's audience centered, it's developed through meaningful partnerships with communities and addressing their perceived needs. It can and should be monitored regularly and evaluated consistently. It requires close collaboration and coordination with policy and with service delivery programs and mechanisms. Because to be effective, you need SBC, but you also need all of the pieces to come together to achieve your family planning objectives. So SBC is a science and it's an art, right? We can't be boring when we're trying to reach people. So how is SBC science and an art? Science, because we have to do the research, right? And we have to strategically plan. We have to think about the barriers, the enablers, and so on. And it's an art because we really do need to reach people. This is idea number 4. It's not just enough to invest in SBC, but need to do it well and measure it to know whether it worked, right? This is an example from Zambia where young people needed to be reached, adolescents needed to be reached with family planning content, reproductive health content, and all of the research showed that they didn't have dedicated time and dedicated approaches that would reach them with the information they needed. So a multi-pronged creative approach that addressed their needs was created. Not only was a adolescent wellness day developed, which is here, where a day dedicated to young people to come and have their own time. And it was called Wellness to make sure that they could get information not just about reproductive health, but about malaria, about personal well-being, about keeping themselves healthy, about self-care, about future goals, and so on. And so they were excited to come and access these services, right? Because they felt special. One of the other challenges that our research showed us that they felt that it was not a confidential counseling session. When they met with the healthcare provider, they felt that their information was not confidential. So a training was created for the healthcare providers called NIZI, which means shh, keep it to yourself. And once the providers went through the training, they would receive a badge that says NIZI, and also they'd sign a pledge that says, I commit to keeping everything my clients tell me completely confidential. And on the table would be a tent stating a confidentiality pledge to remind the young people that they will keep this information confidential. And this increased the trust that the young people had in the healthcare providers and allowed them to come and access the services. And in addition to that, information about reproductive health got out through roadshows, comic books, post little comic strips on social media platforms. So it wasn't a question of boring lectures, but reaching young people where they would be interested and how they would be interested, right? So the 4 ideas to sum up: there is no ideal public health outcome without SBC. Investing in SBC is cost effective. SBC should be the steering wheel and not the spare wheel. And it's not just enough to invest in SBC, but we need to do it well and measure it to know whether it worked. I'd like to share a small video with you that illustrates this concept. So join me in watching this.
Social and behavior change, or SBC, is an essential component in achieving countries' family planning commitments and global development goals. SBC interventions use a deep understanding of human and societal behavior to increase adoption of healthy behaviors and influence the social norms that underpin those behaviors. There are 3 key reasons why SBC is an essential component of any family planning program. First, SBC is rooted in global evidence and best practices and shown to increase successful outcomes in family planning. Second, SBC approaches complement service delivery investments. And third, SBC demonstrates a high return on investment in both the short and long term. Let's take a closer look at each one of these. First, global evidence shows that SBC improves family planning outcomes. SBC interventions have been proven to positively impact intermediate outcomes, such as approval of family planning and open communication with the partner, and have a direct effect on modern contraceptive use. For example, the Nigerian Urban Reproductive Health Initiative was able to increase modern contraceptive use in one city by 15% by using multiple SBC approaches, including TV, radio, and community engagement. Second, SBC complements service delivery investments. SBC interventions improve health outcomes and enhance efforts along the service delivery continuum before, during, and after a person goes to a health facility. In Rwanda, the Bandepahero project created a supportive environment before women went to family planning services by holding counseling sessions in the community with women and their male partners. The project resulted in multiple positive health and gender-related outcomes, including an increase in modern contraceptive use, increased support from men for reproductive choices, and improved decision-making power for women. In Indonesia, mass media and community education were used to improve clients' participation in family planning counseling sessions. As a result, more clients prepared questions for their family planning provider prior to their appointments and improved their communication with the providers. Third, SBC demonstrates a high return on investment. Peer-reviewed research has shown that SBC interventions are cost-effective and provide a high return on investment. Data from Zambia and Guinea has shown that every dollar invested in high-quality SBC to improve family planning uptake saves between $2 and $6. Achieving family planning goals is within our reach. When we invest in high-quality SBC interventions, we can amplify our family planning work.
So by the end of this session, these series of sessions, we hope that you will appreciate that SBC is an important part of achieving good family planning outcomes. That you'll be exposed to something we call the SBC Flow Chart, be familiar with terms like behavioral economics and human-centered design and the role that they can play in SBC. Understand the fundamentals of monitoring and evaluating SBC programs. Have a cheat sheet to be able to critically look at the SBC programming and ask the right questions to ensure quality. And also access a list of curated SBC resources to go through later and share with SBC practitioners in country, including things like the video that you just saw, tools and other great ideas that you can share. So thank you for your patience. And I hope that you feel like your glass has been stirred a little bit, and we'll stop here until the next session.
So now we're going to move into the define section of today's course. But before we dive in, I'm going to briefly give you an overview of the SBC Flow Chart so you know a little bit more about what that means. So the SBC Flow Chart is Breakthrough Action's design process for developing SBC activities to address health and development challenges. The flow chart draws from and incorporates learning strengths and methodologies from 5 different disciplines, including social and behavior change communication, design thinking, behavioral science, community development and engagement, and marketing science. So phase 1 is the define phase, and in the define phase, we're assessing existing knowledge and information and really focusing on deepening our understanding of the problem and its complexities. And we do this by establishing empathy with beneficiaries and various stakeholders and influencers to really uncover new perspectives and insights that are going to inform the development of the SBC activities. Then in phase 2, the design and test phase, we build from that deeper understanding that we developed in phase 1 to ideate and refine and prototype different solutions with communities and key stakeholders. So this is really a developing and testing not yet final versions of potential ideas and concepts within the context where those solutions would be applied. And then once we've synthesized testing feedback into a prioritized suite of solutions, then that's when we move into the third phase, the apply phase, to start progressively implementing those solutions with a lot of real-time monitoring and evaluation to assess their success, and also, most importantly, to continue to adapt and refine those solutions to improve them during scale up. So the design process never ends, if you will, but that is a very broad overview of the flowchart, which I hope will help orient you as we go through the rest of the sections in today's presentation. And with that, I will pass it back off to Utra.
Hello, and welcome back. We're going to talk a little bit about the flowchart in the second segment, which is a phase that we call define. And in this phase, we want to discuss the SBC flowchart and how we might look at existing knowledge. Do you board a plane and decide where to go? Seems like a silly question, right? You never do that. You probably decide where you want to go and then board the correct plane. But oftentimes what we end up doing is we decide the path we want to take or the approach we want to use without really thinking about where it is we want to finally go, right? What is our goal? What is our vision? Why does a country program decide on SBC interventions to be used before deciding where they want to end up? They say, let's do posters, let's do radio programs. Is that the right vehicle? Is that the right airplane to be flying? Should it be is that the best airline, right? So to decide the right airline to use and where you want to board it, one needs to really understand where you want to end up first. So think about our fictional country X. Adolescents aged 15 to 19 have a high rate of pregnancy. About 55% of girls become pregnant by the age of 19. The Ministry of Health is concerned about their early age of childbearing and the implications for the health and well-being of young girls entering motherhood, in addition to the concerns about their completion of education and their employment opportunities. Fair, right? Ideally, where we want to go is what? Not reduction of teenage pregnancies by 5% or 2%. No. Let's think big picture, big sky. No unplanned pregnancies in girls under 19. That could be our big sky. This is the gold standard, the shared vision. We all want that, right? Families want that. Governments want that. NGOs want that. The girls want that, right? We hope so. Unplanned pregnancy. So if a pregnancy is not planned, then it is something that we want to address. This is the shared vision. And unless we start with the gold standard, we can't define the path between here and there, right? We can't know where we'd like to ideally go. If we want no unplanned pregnancies in girls under 19, where are things now? Where are things now? And why is there a difference between where we are now and where we want to go, where we want to be, right? Right now it's 55% of girls under 19 getting pregnant, and that's not what we want. So the difference is what we need to understand. Why is there a difference? So what questions, if answered, would help you figure out what to do to get there? What kind of questions might you ask? Pause this video and write down a few questions that might help you figure out how to get to your vision from where you are right now. So the first stage, really, we want to look at inquiry. Analyzing the situation, analyzing the programs that are currently addressing teenage pregnancy and what are the capacities of programs, what are the shortcomings and so on. and analyzing our audience, right? What is the social or behavioral problem? We want to go beyond assumptions. We don't want to sit at a desk and make up what we think it is. We do want to do a desk review of existing information and formative research to fill the gaps where there isn't existing information and glean further behavioral insights to understand more about the behaviors. When we bring together the key behavioral insights around barriers and enablers for these young girls and collaboratively, then we decide where to begin or to focus. How do we collect this information that we need? Think about the following potential questions. What is the purpose of our inquiry? Who should be involved? Is it community-led? Are we looking for quantitative or qualitative data? Will the chosen methods generate the type of information that we need? Do we need to generalize? Do we need to generate a hypothesis or test a hypothesis? Who do we need to talk to? How many people? What are the analytical capabilities of our team? And how much time and resources do we have? We love to talk about this one philosophy at our center, which is the focus, demand, sacrifice. Sounds dramatic and sounds cruel, but the truth is we can't do everything well. And in doing everything, we may achieve nothing. So to focus and to achieve results, effective results, we do have to sacrifice the things that are nice to have, but not core and essential to this program. From the key insights that you've derived, pick the one to focus on first. Pick one. Pick one for different reasons. The criteria for choosing the one could be because it's the easiest one to tackle first, a quick win, low-hanging fruit. Or it could be a challenge that affects the largest number of people. Or it could be the challenge that is the hardest to tackle. You've got other things fairly under control, but this one is the toughest nut to crack and you want to address that. Or it could be a different criteria. But be clear about why you're choosing that one to pick and choose on that first. Consider the socio-ecological models. An individual's behavior is not just his or her behavior. It's influenced by a number of factors at the individual level, by the family and peers and networks, community, society, and a program to overcome all of these barriers, normative and social, will only then lead to normative and social and behavior change, right? You cannot just address the individual and expect them to change their behavior. The barriers could be at any one of these levels, maybe more than one level. How do we address those barriers to make meaningful change? So for this, we need to segment our audiences to understand them better. I like to think of audience segment like an orange. So you have different segments, and each segment has its unique characteristics. And audience segmentation can categorize the audience into logical groups to make a better fit between the messages and information and persuasion and this particular audience segment. Why do we want to segment audiences? Because we don't have unlimited time and resources, right? We have to spend what we have effectively. There's also a trade-off between reach and intensity. I like to think of it this way, like a piece of butter on a piece of toast. You can either spread it thin and across the whole piece of bread, or you can have it thick and have it just on one part of the bread slice, right? So if you can't have the same amount of thickness everywhere because that's all you have is one pat of butter. So there's a trade-off between reach and intensity. You can either reach a lot of people with a little information or a small group of people with a lot of intense information. And when you segment audiences, you can do that intense reach better. Different people may have different information needs. Their own unique characteristics may be different. And different people may have different tastes, values, worldviews, sense of humor or preferences. And almost always it's not the same as your own. So we're not designing programs for us. We're designing programs for our audience segment. And we have to remember that. We deal with a wide range of human behaviors, cultures, values, beliefs, literacy, message preferences, media preferences, and so on. Who is the key audience segment for your behavioral challenge and why? Think about that. Who is the key audience segment for your behavioral challenge and why? And what change do you want this segment to make? Let me give you an example from COVID. Say you discover that most of the COVID infections are happening in public transport in your city, especially buses where masking is not consistent or correct. So in this example, where do you want to go? Everyone on the bus is consistently and correctly masked to minimize the spread of COVID-19 in that environment. This is your gold standard. This is where you want to go. This is your vision. Where are we now? What's the behavioral or social problem? People on public buses in City X are not masking correctly and consistently and therefore facilitating the spread of COVID-19, right? So they're not masking, and that's the behavioral and social problem. Who is your audience segment of focus for this intervention? They are the commuters and the passengers on the public bus who are not wearing the mask correctly and consistently. They are not the ones who are wearing the mask. So you further segment your passengers into those who are and who are not wearing masks. And what change do you want these non-maskers to make? You want them to wear a mask consistently and correctly when they're on the bus. That's the behavior you want them to practice, right? So we'd love for you to work through this scenario, this sort of an example. And in our scenario, the adolescents aged 15 to 19 in country X having a high rate of pregnancy, 55% of the girls become pregnant by the age of 19. The Ministry of Health is concerned about early age of childbearing and implications for the health and well-being of young girls entering motherhood, in addition to concerns about completion of education and employment. What we'd like you to do is, at the end of this segment, pause the video and consider, where do you want to go? What's your gold standard vision? Where are we now? What is the social and behavioral challenge? Who is your audience segment of focus for this intervention? And what change do you want this segment to make? Now, remember that if the social or behavior challenge may not be related to the audience that is beneficiary. It may not be the young girls. It may be the service providers who are not counseling empathetically. It might be that the parents or the families of the young girls are not supportive. It could be that they don't have self-efficacy. It could be any number of reasons. So you have to be careful to understand who your audience segment is, whose behavior you want to change, right? So the beneficiary may be the young girl, but is she the audience for our intervention? Something to consider. So we invite you to work through this exercise, this first exercise, and answer these 4 questions on your own time. Hi, and we're back at the third segment, which is design and test. You remember the SBC Flow Chart, and we've talked about define, which is the first step. And now we're moving into the second step, which is design and test. I always like to think of my audience as wearing a button that says, how does this help me? So any intervention or any behavior we're trying to get people to change or do something new, imagine that person asking you back, how does this help me? And then it helps us really think more seriously about, is there some benefit in this for the audience? What is the change we want them to make? So the audience segment in our example is travelers on public buses, remember, who are not wearing masks. And the change that we want all the passengers on the public buses to make is to wear a mask all the time and correctly. So consistently and correctly when they're on the bus in order to reduce transmission of COVID-19 on buses. So the questions we have to ask, why are some people not wearing masks? What are their barriers? And dig deep to get into the bottom of why. Why are they not wearing masks? Maybe they don't have a mask. Maybe they feel claustrophobic in a mask. Maybe they feel they don't believe COVID is real. Then each of those reasons you dig deeper. The second point is, why are some people positive deviants? Why are some people wearing masks? What's the reason they do wear masks? Are they facing the same barriers as those who don't wear masks? And how did they overcome those barriers? If not, then what makes them wear the masks? It's as important to understand why people do practice a positive behavior as it is to understand why some people do not. So the steps to behavior change is something that is important to recognize, because not all of our audience is on the same step. Pre-knowledge, some people don't even know about COVID. They are not even aware that COVID can be stopped by wearing a mask. Knowledge. When they know about COVID, how it's transmitted, and perhaps know that masks are being recommended as a way not to pass COVID on from one person to another. Approval is of two kinds. One is approval of the method of protection. We're suggesting mask wearing as a way to protect yourself from COVID-19. So that is approval of the suggested solution. And once they approve that, they also have to think that the people around them approve or disapprove of this practice, right? Is it their social support, or do people make fun of people wearing masks and think they're weak, right? So social approval or community approval from their peers is very important. As important as approval of the method or the intervention that we're asking people to perform. The next step is intention. And this is an interesting step, because you may know about the solution, you may agree that it might work, and you may think that people support you generally in wearing a mask, but do you intend to wear a mask yourself? So that's the next step, intending to wear a mask. But as we know, there's always a big gap between intention and practice, because you could intend to wear a mask, but it's a long way to practice. You may forget your mask. You may not have bought a mask yet. You may have left it as you left the house. When you get on the bus, you may realize there's a couple other people not wearing it. You want to wear it, but do you actually wear it? Too much of a bother, right? So those are all big gaps between intention and practice. And finally, once you practice it well enough, often enough, that it becomes a habit, you advocate for it. You tell other people, hey, I wear a mask, it protects me, you should wear one too. So self is at the middle. This is the sociological model again, looking at it. We are in the middle. Individual behavior is influenced by all these layers of the onion around it. Interpersonal relationships, partners, family, spouse, etc. The community we live in, leaders, providers who influence us. The enabling environment that we are in our countries or our cities or towns. What kind of policy legislations exist, the political and economic climate, religion, technology, natural environment, etc. And these are very much determined by government, NGO, and private sector. And through all of this, there is the information we get, the motivation, attitudes and beliefs, ability to act, which is the skills, self-efficacy and access, and the norms, perceived sociocultural gender norms. And these cut across all of the layers, influencing an individual's behavior and their ability to act. I want to delve into behavioral economics here for a second, because it hugely influences individual behavior. You may have heard of this. It's a fancy term, but it really is a new discipline, not so new anymore, which is an overlap between psychology and economics. And behavioral economics uses insights from both economics and psychology to more deeply understand how people form intentions and make decisions and take actions or not take actions. So when we think about the steps to behavior change, behavioral economics tends to fall somewhere after approval and before advocacy. In the intention and practice phase is where the behavioral economics principles really strongly come into effect. There are many concepts within behavioral economics, and we'll just discuss a couple of them today, just to give you a sense of how it might work in the context of reproductive health. Framing is one of them. Imagine a painting that's been done by your 3-year-old niece or nephew or kid, and it's a scroll with lots of splashes around it. If you put the same painting in a fancy frame versus a very simple frame, it might be the difference between someone thinking it's modern art and someone thinking it's something your child gave you that you framed, right? And the painting is the same, except the way you framed the content is different to attach a different type of a value to it. This is an example of framing. You making the right choice or the choice that we want to guide people towards easier or more obvious, to make it feel good, popular, attractive, simpler, etc. Right? You have 2 cans of yogurt. One says it contains 20% fat, and the other one says it's 80% fat free. Right? Which one would you choose? Most likely the one on the right that says 80% fat free. Now, those of us who know simple mathematics clearly understand that there's no difference in the fat content between the 2 containers. However, it makes us feel better to choose the one that says 80% fat free, right? So this is simple behavior and economics framing in action. In Nepal, for example, family planning used to be framed as 2 children are a blessing from God. Now, the modern generation is very much attuned to the word smart, whether it's a smartphone or smart decisions. And so using that or piggybacking on that, the new family planning slogan reads, family planning makes life smart. And in fact, in the Nepali text, the word smart is used as that word. And it's aspirational. It frames the same behavior of family planning in a positive way to help people feel better about that choice. So how do we design interventions that keep audiences at the core of it? Because we're not designing for ourselves. What we like may be something entirely different than what the audience wants to see. And we have to really keep them at the center of it. And this process is called human-centered design thinking. Human-centered design thinking at its core is a creative approach to problem solving. When we're little children, we are unafraid to be creative, right? And as we get older, we're afraid to make mistakes, afraid to be creative. We want to do things that we think are safe, right? And this approach really turns that on its head a little bit. It starts with people you're designing for. It's human-centered. And then it ends with new solutions that are tailor-made, that suit the needs of their needs, the audience's needs, not yours or mine. And why do we use human-centered design thinking? Because it brings together solutions which are desirable from a human point of view, and then what is technologically feasible and economically viable. And when those 3 things intersect together, you have your sweet spot, right? And when they overlap, the desirable, feasible, and viable. Here's an example from real life. What we have here is an MRI machine. And as any of you who's been inside one of these will know that it doesn't feel that great. It's a little bit unnerving. It makes all these whooshing sounds, and you might feel a little claustrophobic. And if you and I feel this way, can you even imagine what it must feel like for a little kid? So one pediatric hospital really struggled with making this experience not so intimidating for young children. And so they undertook a human-centered design process, keeping the children at the center of the solution. And when they came up with ideas, what they finally came out with in the end was something quite phenomenal. It looked like this. It became a submarine. It was an exciting adventure that young people would be told a story, and you'd feel like you're going in, and the sounds and the whooshing was all incorporated into part of the story. So ultimately, it felt more like an adventure rather than a medical procedure. And the kids were so excited to the last one, they said, "Oh, can we do it again?" Right? So that transformed the experience for the young ones, instead of being something intimidating to being something fun. Pre-testing is extremely important when we come up with new designs, new ideas, and new interventions. And when you are presented with some ideas and say, "Oh, this is the campaign," the first question we need to ask ourselves is, was this pre-tested with the intended audience? Understanding the audience's reactions, their thoughts, on what we're trying to do before implementation is really, really important. Pre-testing checks to see what has been designed is really suitable for the audience. It makes sure that the material is understandable, it's culturally appropriate, believable, realistic, acceptable to the audience, appealing, and motivational. And if we get it right after pre-testing, it saves us money, time, and energy. Because sometimes if you have ignored some of those major issues and it's culturally unacceptable or not really understood, we may end up wasting a lot of money producing something in its final form when it wasn't appropriate at all. This is an example from northern Nigeria of 2 family planning posters. This is the NORI campaign, NORI supported campaign and the government of Nigeria. It's a family planning campaign called Know, Talk, Go. The 3, know the facts about family planning, talk to your provider, partner about family planning, go for family planning, right? So here's the campaign that the posters that were pre-tested. And the one on the left is before pre-testing and the one on the right is after pre-testing. While they may look exactly the same to you, there is a small but very important difference. Underneath the red jigsaw puzzle piece, the first one says go for family planning. And the second one says go for childbirth spacing. Now the difference is the word childbirth spacing versus family planning. Family planning was seen in this community as population control. And there was a lot of pushback and it would have been unacceptable. But talking about it as childbirth spacing was acceptable. So pre-testing helped the project determine what was and was not acceptable. And it really saved the project a lot of resources to help them be accepted. So some key principles. This also includes partners, and you must include partners and stakeholders in the design process. So there's buy-in and ownership, and this is good for sustainability. You'll agree that unless there's partner buy-in and they feel like they've really been part of the process, it's not going to sustain. And how long can a project continue to put out materials or campaigns or interventions unless it's locally accepted and owned by the people who need to take it forward? So testing concepts and messages with audience partners and stakeholders is very, very critical. Being open-minded to and trusting the process and being willing to accept outcomes is also very, very important. We don't want to pre-test just in a token way, but truly be willing to accept any changes that come or suggestions that come if we want to make this a better intervention. So now we get to our second exercise. We want to think about who the stakeholders are other than the audience that should be involved in this process. They could be parents, they could be caregivers, they could be politicians, they could be school officials, they could be religious leaders, it could be any more or combination of them. But it's important to think about who should be involved, right? It could be other family members as well. And what key benefits could you offer the audience? The benefits should be believable, relevant to the audience, and motivating. So here's an example of how you could frame it. In your example, you say, if the audience is girls 13 to 19 years old, your key benefit statement would read the following way. If you practice behavior X, so in this case, use a contraceptive method to avoid pregnancy, you can benefit by, the key benefit you're offering this young girl is finishing education on time and securing a future where you can earn well. So she's not just told prevent pregnancy by using a contraceptive method. She's also given a believable and powerful benefit to doing that. Now, this is one benefit. You may want to offer some alternate benefits as well and see which one resonates the most with young girls 13 to 19. And for that, you may need to pre-test these key benefits. And whichever one has the most traction or is most understood or liked by the young girls would be the one to use to promote the behavior. So I will end there and let you take a little bit of time for exercise number 2. Think about the adolescent girls and what you might offer them. I only offered one of the multiple possible key benefits. Perhaps you have other ideas. And this is something you could apply to any audience once you know what the desired behavior is that you want them to practice. So good luck with your second exercise.
Okay, welcome back everyone. We are excited now to move into the next phase of our session to discuss some key issues related to implementation, monitoring, and evaluation. As we've done so far, we're following the flow chart, and so we will be discussing these issues under the third phase called apply. Now, as you can see on this slide, what we're calling the apply phase includes a number of key aspects related to program implementation and monitoring, evaluation, and adapting for scale. Now, once you've designed and tested different prototypes, as the previous sessions have highlighted, this phase highlights the implementation of those important solutions, whatever those solutions are. Then we use real-time monitoring and evaluation to examine what is working, what is not working, and make adjustments as needed for scale up. We'll focus on a few key issues related to implementation, monitoring, and evaluation today, but there are a number of important resources we are making available to you that will be useful for other topics as well. Now, a critical piece of effective implementation is a program's implementation strategy. Building off of what we have learned in define and test and define and design and test, this strategy should include details about the who, the what, the when, the where, and the how. We want to be thinking about how can the audience that we've chosen to focus on be reached? Who are the particular influencers of that audience? What are the intervention approaches we want to use? What are the activities? What are the channels? And how often should we use those channels? We've highlighted a number of different communication channels here, ranging from electronic media to social media to community media and even interpersonal communication. Programs must be strategic about what intervention mix they will use, the justification, why they've chosen to use that intervention mix, and what their particular audiences of interest are. Now, this slide shows an important template that can be really helpful in organizing your implementation strategy. This template can help you think through the different channels you want to use, the preferences, the cost, the reach, and even the specific details related to timing and frequency. For example, say we are interested in working with providers to address provider biases related to sexual and reproductive health. As a result, we decide that we want to use interpersonal communication, digital media, perhaps even some community media. This template helps you think through the details of those choices. Which do you prefer? What are their costs? What is the reach of each of these different approaches? When and how often will you use that channel? And costing and budgeting, as you saw on the previous slide, is a key component of a good implementation strategy and effective implementation. This is important for individual programs, but it's also important for larger social and behavior change initiatives to reach country-level commitments. And so Breakthrough Action has worked to develop a really useful checklist that can be helpful for governments, donors, and even individual partners to make sure that SBC is sufficiently integrated into and costed and budgeted for in family planning costed implementation plans. This resource is part of the final set of resources that we'll share as part of these sessions and is one that should be really useful for you in your work. So once an implementation strategy has been thoroughly developed and solutions are in the process of being implemented, the important question remains: how do you know how your program is doing? In fact, effective implementation requires frequent data collection from a variety of different sources to troubleshoot hiccups or unplanned challenges. That means not only monitoring in real time how things are going, but also committing to evaluating different approaches to help us understand how and why something is working or not working and to what effect. Monitoring and evaluation help us to make critical decisions that influence subsequent implementation and, ultimately, scale up. So why are monitoring and evaluation important? Monitoring and evaluation are key to helping us understand the how and the why of whether something works or doesn't, and to what effect. So in this way, when we're talking about monitoring, we're referring to continuous learning. Monitoring is not only about indicators, which we'll talk about in a few slides, but really about keeping track of events as they take place in a project. By doing this, monitoring outputs, estimating coverage, you're able to see whether the programs are being implemented as planned, if they are achieving what they're intended to, and what necessary adjustments are needed along the way to maximize impact. Now, this continuous learning process allows for better adaptive management. This means integrating not only the collection of data, but the review and analysis of those findings in real time on a regular basis, on a routine basis, to gather insights about our programs and to make critical decisions as new information comes in. So, before we go into more depth to think about monitoring and evaluation, we have an important question for you, and this is one that we want you to reflect on for a little bit. What could be important to monitor during the implementation of a family planning program? What do you need to know during a program to be able to say how it's going? Well, in some of the family planning programs that we've monitored, some of the things you might want to think about are things that your program is working to create. For example, how many different episodes, how many different materials are being developed. But then you also want to think about how that implementation is going, who is being reached by those materials, and then ultimately, is that making any sort of a difference? Are people changing their thoughts or their attitudes about contraception or about sexual and reproductive health topics? Are people talking about those topics with one another? And are we seeing any sort of shift in behaviors? Those are some of the things that I might think about monitoring in a program related to family planning. What are some of the things that you think could be important to monitor? Hopefully you took a second or two to think through some of the things that you might think are important to monitor. And hopefully you also noticed that some of the examples that I gave include both process and output types of indicators, as well as more intermediate types of indicators, thinking through not just what the program is doing, but ultimately what are the effects of what that program is doing. So one useful way of thinking about monitoring is breaking it into two pieces. First, process monitoring, which you see on the left of this slide, and second, outcome monitoring, which you see on the right. First, process monitoring. With process monitoring, we're talking about counting, tracking, or collecting data on that implementation process itself. How well is the implementation going? How many people have been reached? Are there variations by different types of people or by different locations? What is the cost of that implementation? Second, in terms of outcome monitoring, this refers to the monitoring of the changes you might see in the outcomes you're expecting as part of your project. Do you see the changes that you're expecting? Why? Why not? What could be improved? And so once you start to think about monitoring in this way, you realize that there are many different data sources that you can use for monitoring. For process monitoring, for example, when you're thinking about the implementation process itself, data sources often include things like programmatic records, logs from radio or television stations, maybe even websites or social networking sites, content communities, satisfaction surveys, maybe even qualitative data that could include focus groups or in-depth interviews. Now, on the other side, when you're thinking more about outcome monitoring, starting to think about the outcomes of your program and what you're trying to see change and whether that change has happened, data sources can include things like a review of data that already exists. That could be routine health information system data. It could be even education information system data. It could also include nationally representative surveys, census or other vital statistic registries. It could also include other population-based data collection approaches or community surveillance or even rapid assessments. Qualitative research can be really useful at a smaller scale. That can be quite useful at looking at local level changes. And complexity-aware methods that are participatory and qualitative, such as most significant change, can be really useful as a monitoring tool. So we've been starting to think about monitoring in new ways, process and outcome, and we've been brainstorming the many different data sources that exist that might have information relevant to us. These data sources help us get information, and they help us get information on specific indicators. So the question remains, what is an indicator? Simply put, indicators are tools that help us measure how an SBC program is doing at whatever stage you're thinking of. They give you specific information that is measurable, that help us to understand specifically if program objectives are being met or not. And they often have specific definitions. Now, program indicators, to be useful, should be guided by your program objectives as well as your implementation strategy. These indicators are essential to helping your monitoring and evaluation team organize their activities. We often break down indicators into process, intermediate, outcome, and impact indicators, which we'll talk about in a few slides. Now, as I mentioned, program indicators are best when they are guided by your program objectives and are used to help orient your monitoring and evaluation activities. The best program indicators are SMART. Now, SMART is a really useful acronym for those of you who are less familiar that can help you develop indicators that are really useful for your program. The best indicators are specific, meaning that they are related to a certain behavior, attitude, or other particular health area of interest. They are measurable, which means that it is something that you can actually collect data for. They are attainable, which means they are possible. They are relevant, that is, they're relevant to your program's objectives and activities, as we've mentioned, and they're time-based. For example, number of health providers trained on family planning counseling, that is most useful when we provide a time-based element. For example, the number of people trained during the last 6 months. So when we think about indicators, when we think about monitoring, we often think about indicators. But why are they useful for us? As you see on the left of this slide here, indicators help us measure two really important things. First, the effort our program puts in on the top, and at the bottom, the actual effect of our efforts. So in terms of effort, how much we've done, how well did we do it? And in terms of effort, is anyone better off? In what ways? What changes have we actually seen? Now, to put it in other words, to use the language of indicators, process indicators are those indicators that help us to measure the effort our program is putting in terms of how much we've done. Now, those more intermediate indicators are those that are helping us to think about how well we've been doing those things. Are we starting to see change in the places that we would expect to see change if we were doing things with quality? Those are the intermediate changes that are helping us push us towards the effects we're looking for. Now, finally, outcome and impact indicators are those indicators that help us to measure the effects of our efforts, how people are better off as a result of the work that we're doing. And so we can start to think about specific SBC indicators related to family planning at each of these stages, from process to intermediate, to outcome, to ultimately impact. Now this slide, although the font is quite small, highlights some useful indicators that can help give you a sense of what an SBC program working in family planning might consider monitoring. In the process column, those indicators that help track implementation are included. And we can think of these as indicators such as the number of outreach activities connected with youth, conducted with youth, or the number of decision makers reached with advocacy activities, or even the percent of the target audience that recalls seeing a specific message about family planning on social media. Now, USAID standard indicators are really important to consider here as well. And for example, one indicator that many missions, in fact, all missions should report on a yearly basis is the number of individuals in the target population exposed to U.S. government-funded family planning messages through radio, television, electronic platforms, community group dialogues, interpersonal communication, or in print. This is a really useful indicator that helps to assess reach of program messages across channels. Now, that would be a great example of an indicator that one would include here for a family planning program. Now, as we move towards more intermediate indicators, we're thinking about tracking how programs are starting to be effective. Here we're considering those intermediate factors that lead to changes in behavior. Those could be things like knowledge or perhaps confidence or even self-efficacy. For example, the percent of your audience that is confident that they can use a contraceptive method, or the percent of women who can mention at least 2 modern contraceptive methods. Many of the factors included in this intermediate section can be described as ideational factors, which we'll discuss in a bit more depth in the following slide. Now, outcome indicators help us to see how our program is doing related to our specific outcomes of interest. These are things like key behaviors such as current modern contraceptive use. And then finally, impact indicators help us to track how successful our programs are at achieving those larger programmatic goals related to family planning. Now, this could be things like reductions in maternal and infant death, maternal morbidity, preterm birth, as well as others. Now, what we'd like to do is to share an excellent video from the Nigerian Urban Health Initiative. This video highlights how SBC programs use research monitoring and evaluation to assess the success of their programmatic activities. And what's great about this video is that they highlight how ideational factors were integrated into the key indicators that the program monitored for success over the life of the project. So take a look.
Decisions people make and act on depend intimately on the ideas and feelings they have. Therefore, to influence a person's decisions, we first must address their underlying beliefs, emotions, and perceptions. So when the Nigerian Urban Reproductive Health Initiative set out to improve women's health by increasing the use of contraceptives, we started by exploring people's ideas and feelings about family planning. Our initial results helped us identify a set of specific ideas and feelings that predicted whether a woman would or would not use contraception. The more of these predictors that a woman had, the more likely she was to use family planning. This concept is known as ideation. And what were some of these specific predictors? When a woman knew about family planning, when she had a positive attitude towards it, when she had fewer mistaken beliefs about it, when she talked to her husband about it, when she believed that her friends wouldn't criticize her for using it, and when she approved of religious and political leaders speaking about it, then she was far more likely to use it herself. We utilize these predictors to build messages for our strategic communication program. Using ideation in our efforts has been successful. In fact, the results have been measurable. Over 300,000 women who were previously at risk for an unintended pregnancy are now using family planning. Between the baseline and midline research surveys, levels of modern contraceptive use increased in all 4 program cities. This has allowed Nigerian women to have more control over their reproductive lives, which is good for their families and communities as well.
Great. Now, SBC indicators can be quite tricky, and there are a number of important resources available that can support you in efforts to identify the important indicators for your program. Our sister project, Breakthrough Research, has helped to synthesize a set of priority recommended SBC indicators specific for family planning. These include indicators from process to intermediate to outcome indicators. They've also collected indicators used in a number of different family planning programs in West Africa, both in French and in English. These resources can be tremendously helpful when developing a program and working to monitor it. We will include these resources as part of this session as well. Now, importantly, as we've seen over the last few slides, indicators play a really important role in helping us to monitor what we're doing and the effects our programs are having. The development and selection of indicators, however, is critical. We must make sure that we consider a number of different factors when identifying what indicators will be used and what indicators will be important to prioritize over the life of a project. Often we end up with too many indicators, so synthesizing a priority set of indicators is key. First, we have to think about what our program's goals and objectives are. What are we working towards? Then we want to think about our program's theory of change. If you're implementing using the socio-ecological model, for example, and have activities at multiple levels, what indicators will you use to monitor those activities at each of those levels? If you consider the image on the right, for example, indicators can help you to monitor in real time factors at the individual, family, and peer network, community, and even societal levels. Furthermore, you should consider your program's audiences and implementation strategy when identifying the relevant indicators and even the disaggregates for those indicators for your program. As we've outlined, indicators should not only focus on process, but start to think about intermediate, outcome, and impact as well. By doing this, we can ensure that our indicators are building on the guiding principles of SBC, informed by theory, evidence-based, practical, and rigorous. Now, as we progress with the implementation of our programs, we must think not only about monitoring, but also about evaluation. Evaluations help us to answer all of the questions on this slide, and perhaps even more. Questions like, how well did we do and why? What was successful? What happened? Did we reach our goals? Are the changes that we're seeing in the communities where we're working as a result of our program or as a result of something else that happened at the same time? What can we improve for next time? Evaluation is an essential aspect of any SBC program, as it helps us to answer these questions. And what evaluation is really the systematic gathering of information to provide feedback on a program and to estimate its impact. Evaluation helps us to see if our project's objectives are being met, why, and what can be learned from the future or for the future. Now, there are a number of different evaluation approaches, and we could spend all day working through the nuances of each. What we are hoping to communicate here is that there are a number of different evaluation approaches and that they depend, just like monitoring and indicators, on the goals of the program. Your evaluations can vary by scale and generalizability, from small scale, less generalizable assessments like audience receptions or focus groups to more large scale evaluations using population-based surveys. They can also vary by method, from quantitative to qualitative, and by objective, from impact evaluations to looking at cost effectiveness to perhaps using complexity-aware methods like most significant change or outcome harvesting, both of which can be quite useful in evaluating SBC and family planning programs that are focused on capacity strengthening. There is no one-size-fits-all evaluation design. And so what we're hoping that you can do is to revisit some of the questions that you've been working through as part of the previous sessions, and to build on it now some thinking about monitoring and evaluation. Based on what we have talked through today, what might a program focusing on adolescent sexual and reproductive health decide to monitor during implementation? How might you measure success? And so we would encourage you to ask these questions and think through indicators along this line, from process to intermediate to outcome to impact. I have provided a few examples on the following slide just to give some thinking about what that might look like, but I encourage you to think in more depth about the type of projects that you're proposing and what will be most useful for monitoring success. Before we wrap up, I did want to share some of the examples that I've pulled together for this exercise, just to help give you a little bit of a Kickstarter inspiration for some of your own thinking. So if you were thinking about an adolescent sexual and reproductive health program and thinking about monitoring activities from process to intermediate, outcome, and impact, some of the things that I might start to think about would be whether adolescents were involved in the design of materials and activities and in the implementation of the program. This sort of builds back to some of what we discussed in previous sessions about participatory and really community engaged work, such as human-centered design. You might also want to think about indicators like the number of unmarried adolescents who participated in community SBC activities, and thinking about what you might disaggregate those data by. So if we want to take more of a gender-sensitive approach, making sure that we're disaggregating by sex so that we can understand differences between adolescent girls and boys, and even people of other genders. Now, if we look more at intermediate indicators, this could be something like the percent of adolescents who are confident that they could get their partners to use contraceptives if they desired. Again, disaggregating by sex. In addition, you could think about couple communication, but among adolescents. So the percent of unmarried adolescents who spoke with their partner about using a contraceptive method. And then thinking about that time frame again. So speaking in the last 6 months. Again, disaggregating by sex. If we move more towards outcome, you could consider looking at contraceptive use among unmarried adolescent girls. Or if you're looking specifically at a program focusing on condom use, you might have the percent of sexually active adolescents who use a condom at first sex or maybe at last sex as a way of looking at contraceptive behaviors. And then finally, thinking about some of the impact indicators that might be relevant. Again, this should link back to the goals and objectives of your program, but some that could be considered might be the percent of women aged 15 to 19 who are mothers or pregnant with their first child, so who have started childbearing in some way. Or you could think about adolescent birth rate as another sort of impact indicator that might be relevant to your overall program. These are just some ideas. Excited to see and hear some of what you all pull together as well. And now we will wrap up this session, and looking forward to hearing your thoughts on the upcoming session on capacity strengthening. Thanks so much.
Thank you so much for your time. We are so grateful that you gave us a few hours of your day to talk about SBC and family planning, and really hope that this content is going to be useful for you in your work moving forward. Before I let you go, we would be so grateful if you could take a few minutes to fill out a very brief survey. I promise it's brief. It's available at the link that you see on the screen. Unfortunately, there's not a way for me to push the link out to you through the video, so if you wouldn't mind pausing the video and typing the link into any web browser, it'll take you to the quick survey where you can share feedback with us about your experience in the course. There's also a handout that accompanies this course, and you can find the link to that underneath this video on YouTube in the description. And the handout includes a lot of really useful resources that go into some more detail about the things we discussed today, and are also just really practical and useful in your own work if you're considering incorporating some SBC principles into your programming. So thanks again for your time, and hope you have a wonderful rest of your day.